Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
And mostly just wanting to give sort of bird's eye view and kind of insight as to what I've learned over the last couple of years working on implementing HIV and STI testing outside the clinic setting. And a lot of this sort of had to be accelerated in the setting of COVID, obviously, but I think that more and more people are sort of looking at options for being able to give patients more availability, more access to testing. And so I don't necessarily have a ton of solutions. A lot of this is just sort of what I've learned and then several questions that we'll go over. So no disclosures, this slide here. So just an overview, I'm going to talk a little bit about what some of the service delivery models are, options that we have for kind of expanding access and for testing, and then a little bit about benefits and limitations of some of those options. And I'll talk just briefly about what our local experience has been here with developing a remote care model. And then I think the most important part is just for all of us to be aware of what some of the challenges are, and then a few questions that I want to pose to you. If any of you have gone forward with a process like this, I'm curious to know what your results have been. There are a lot of places that, HIV and STI care are delivered. So we think about kind of traditional sexual health clinics or the classic kind of STD clinic. We have mobile vans, brick and mortar facilities, clinics where you're delivering a lot of your care to patients, and then pharmacies. But I think there is a push to kind of think about where we can sort of push care now outside of these settings. Typically, we're looking at things like HIV incidence going down. However, PrEP coverage is still not great. So really a lot of the patients that we're sort of targeting these sort of interventions to are on PrEP because they have to be monitored quite frequently. And so we want to be able to expand the number of people who can be on PrEP, but that is going to require certain infrastructure to be able to monitor these people. In addition, STI incidence is very much on the rise. That's not a surprise to any of you, particularly for syphilis and congenital syphilis. And so if we could have ways to be able to screen people more frequently, that would be also ideal. All of this is in sort of the backdrop of there being really limited numbers of sort of dedicated sexual health clinics or family planning clinics, places where these services are typically delivered. Budgets are going down. As all of you know, staff have been redeployed to different places and healthcare workers are just burnt out, period. And then adding COVID on top of that, additional operation capacity limitations. And that's where sort of we really in the last couple of years have been trying to move more towards remote care and telehealth, which I think many of you are familiar with. So this is where this idea of kind of home-based services comes in. So I'm using this term kind of broadly to describe having kind of a package deal where you might be able to do telehealth with someone. You as a provider are ordering testing or sampling that someone can do at home. And then any treatment that they would need would be facilitated either at home, delivered directly to them. They would go pick it up at a pharmacy, or they would come into a public, sexual health clinic or your clinic if they needed something like a ceftriaxone injection. There are several models that have already kind of been put into place, piloted mostly in academic centers and research settings, but has been shown to be highly acceptable and feasible across a broad spectrum of locations in the United States. That's kind of where I'm focusing this talk. So just two examples of those quickly. So the one on the left here, PrEP at Home, was done by the Emory Group, and this was sort of a pilot research project focused on men who are on PrEP in these 3 cities. They were able to send out these kits that had 3-site gonorrhea, chlamydia, NAT testing, fingerstick whole blood. And we'll talk about sort of what the options are. You can kind of pick and choose which tests you are able to do. But in this particular case, they did an RPR at a fixed titer, and then also were able to get a creatinine and then an OraQuick HIV. In their study, they did have a pretty good completion, 93%. And the vast majority of people said they would prefer to be able to do this if they could over coming into a clinic. Contrast that with what we kind of see on the left here, on the right in Iowa, a similar program for PrEP, telemedicine model using pharmacists. They actually had to send patients to a public health clinic or another site to have their labs done because they couldn't do them on site. And a limitation of their particular model was that they weren't able to do a lot of extragenital screening because self-collected samples were not acceptable. But 95% of people completed labs, and many were able to get PrEP mailed to their home. So kind of two different models, and you can kind of see, depending on where it's being implemented, there may be some barriers or some kind of pros depending on how it works out. So one thing to kind of keep in mind is I think these two terms get kind of conflated often, and I've been guilty of this as well, but I think it's important to make the distinction just because when you're operationalizing this, it is going to be quite different. So home testing is so a person is actually collecting their sample and then running a point of care test at home, and they're receiving their results at home. So that's kind of like the OraQuick that you may be familiar with. That is different than sampling, where someone is just getting their sample. So say taking a pharyngeal swab, and then they're sending that into a laboratory for analysis, and their results come later. So the reason that's important is because when we kind of think about our menu of options for testing, again, this is not news to you. The only one that we really have here in the United States that's FDA approved as a home test is the OraQuick, and we know about its limitations. If you're talking about a point of care test that can be done quickly in the clinic, an antigen antibody combo to determine, again, that also has its limitations in sort of having lower ability to kind of pick up acute infections. So that's a whole other conversation, but those are two options we have. When we talk about syphilis, there aren't really any home options. All we have is point of care tests. So here in the United States, we've got the syphilis health check, which uses a finger stick sample. It's a two-step test that can be done in about 10 minutes. It is FDA cleared and CLIA waived, meaning it's a pretty low tech kind of test that people don't necessarily have to have advanced training for. Has pretty good performance depending on the population. So obviously if the prevalence is a lot higher where you are, it may not be the best test, but it is an option. And then we have other options that are mostly being used internationally, dual rapid diagnostic tests that may give you an HIV and a syphilis result, either non-treponemal flavors or treponemal tests, or they have some that are combined. When we think about gonorrhea chlamydia, a lot of you are familiar with this. The Cepheid combo expert there on the left, so in 2019 was sort of one of the first ones, and then the Aptima swab, what we kind of use a lot now. The newest update is that in 2019, late 2019, kind of early 2020, this Binks IO platform came on board and got FDA approval to be able to do gonorrhea and chlamydia NATs as a point of care test. And then they also got an expansion in 2022, in just March, a CLIA waiver. So now this can be used in outpatient offices, urgent care settings, et cetera. So I think that's exciting, although I don't know how much it's actually being used. Maybe if any of you have experience with that, I would be happy to know. The other thing that I kind of want to put on people's radar is, patients are really sort of driving their own sort of care, and they want options to do things on their own. And that's sort of lend itself to this sort of direct-to-consumer model. So this is where people go on the internet, they find a company that is willing to have them send their samples, and then they can sort of pick and choose what testing they want to have done. Often this is not affiliated with a clinic, it's proprietary, and the company will send the kits directly to the person's house. And it may or may not include a medical consult, often on an app or sometimes online. And the cost can vary quite a bit. Not all of these companies take insurance. And I always find it interesting just to kind of type this into Google and see how many companies come up. You may recognize some of these: Everlywell, MyLab, Persona Labs, Quest Direct has a platform as well. Molecular Testing Labs, if you're in the Pacific Northwest, is a sort of familiar company that many people are using in Oregon and Washington. And then Nurex, there's a lot of different ones. So just kind of contrasting how these measure up, I think there are pros and cons to each of these. We're very familiar with what they are for a traditional sexual health clinic. If a person, doesn't have funding or can't really pay, I think that's a good option, but it is limited in the sense that usually these are in sort of urban centers and don't have great rural coverage. Primary care and urgent cares, I don't necessarily need to go through that with you, the pros and cons for those, but focusing more on the direct to consumer or the kind of commercial models, I think it's a good thing that it increases access and allows people to be able to kind of get convenient testing on their own schedule with results delivered directly to them. The problem is sometimes the testing can be inappropriate, and there's often limited counseling and sort of linkage to care, and the diagnoses are not always consistently reported. So we kind of became aware of that happening here in Washington State, where our public health staff were getting notifications about syphilis diagnoses or new positive HIV testing, and we couldn't link it back to a provider or a clinic. And it was due to some of these companies that were sending tests to people. They were getting a positive result, but then there was no follow-up. They didn't tell them about how they could find a provider, how they could get treatment, what these tests meant. So we kind of put this PSA out in STD, and then shortly after, the American Sexually Transmitted Disease Association put out their sort of public statement about what best practices should be, noting that really there is no guidance on this officially. The laws are kind of sketchy in a gray area. It may depend on your state, but there aren't really any here in Washington. I wanted to put this up here. I know this is kind of a busy slide, but this is just from my head, sort of what I've experienced over the last couple of years in terms of what a menu might be if you were going to kind of pick and choose for your own program and implementing this, what the options are for HIV and STI, and then PrEP test monitoring options. So if you're doing an HIV test, that's very familiar to all of you, which ones we have that are approved at home, really only the OraQuick. If you're going to do HIV antigen antibody testing, you're looking at getting a lab-derived test, meaning some sort of assay that your lab at your facility is able to kind of internally validate, and then they would say, yes, we can use this here with these different samples. So either a finger stick sample for whole blood or venipuncture. Viral load testing we'll kind of touch on briefly in a second, but really there's only one platform that is around here in the United States, but it is not approved to be used at home. For syphilis testing, same sort of idea, except for that the DPP and syphilis health check can be used in a CLIA-waived fashion, so in a clinic, but this is not something that someone's going to be doing at home. Gonorrhea, chlamydia, the main sticking point with that is that the FDA has not really recognized that people can self-collect samples at home and then send those into the lab. They don't really want people doing that. Although it has been done for many years, it's not really authorized. And so labs are sort of taking on their own risk if they're allowing patients to do that. And I think a lot of lab directors have said, we're fulfilling patient need, and this is really more priority over the kind of the bureaucratic side of things. And then for creatinine, there are a few point of care tests that are available, but not many are really CLIA waived. So I think if we had our way, kind of best of all worlds, we would be able to put together sort of maximizing the pros, limiting the cons in these ways to optimize the delivery model. And I'll kind of end with this here, that this is what led to our kind of local option. So I called it the HOT for PrEP study, which stands for Home Option Testing for PrEP, where we sort of decided we wanted to get a lab-based testing program up and running, but patients could collect their own sample using this device that you see listed here. From the upper arm, does not require venipuncture, and will allow people to get anywhere from 600 to 700 microliters of sample blood that we can then use for testing. And then we're basically had our lab sort of internally validate this, and we're kind of rolling this out as an HIV STD program implementation project. But it is sort of on the auspice of research, so I think that makes it challenging because we're kind of flying under FDA radar in that way. But if you were going to be doing this only with FDA-approved tests, I think it's a little bit different. So the challenges and questions here, I'll leave you with this. Do we know when the FDA will officially approve home-collected specimens for gonorrhea, chlamydia? I don't know that is the case. If Joanne's on the call, I think she's been privy to some sort of back office discussions about this. There are kind of high startup costs for the individual clinics, and this may be something that you have to get administrative and lab buy-in. So I know not every place is allowed to do self-collection of abdomen swabs. And so if that's not something you can do, you really have to kind of work with your administration on that. If you are going to partner with a third-party lab, I think it's really important to make sure the appropriate tests are run. So you want to be able to get, like, for instance, a quantitative RPR to know if someone has a new syphilis test rather than just a treponemal antibody. And then turnaround time is important. So we tried to use molecular testing labs here for our public health clinic early in the pandemic, and turnaround time was like 30 to 45 days, which is not useful at all for clinical care if you're talking about HIV and syphilis. And then also reporting to public health is important. Reimbursement's always a question. Not every insurance will sort of allow testing for all of these platforms. And so you kind of have to know what options you have where you are. And then one big thing that Brian brought up that I think is a sort of an unanswered question in this era is now with new guidance sort of saying HIV-1 RNAs might be indicated for some people on PrEP. How do we manage that? So here at our lab for UW, you need 2 milliliters of blood minimum to be able to run a viral load. And that's a lot of blood for someone to collect at home. And so I think, there are just logistic challenges for being able to kind of operationalize this that I think are yet to be determined. So I know there are point of care viral load tests that are being studied, but we're not quite there. So that is all I have.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.